Good afternoon, everybody. Just going to wait for people to join.
Good, James.
Hi, Andrew. How are you?
Good. Sorry, this came up in my calendar. Could you remind me what IHI is?
Okay, maybe this is coming up in your calendar, but you don't need to be here. Oh, so
Thinking
IHI
about
is a class is a course that I'm running for people who are interested in quality improvement. So they will have signed up to the course. Did this
it.
come to you? Must have come to you via Teams
Through
instead
through
then.
the quality
Did it
quality and
just ping?
governance group team.
Did it just did Teams just ping up an alert to you saying this meeting had started?
Not so much. It came through as one that was sent through to the whole quality and governance team.
Yeah,
That
yeah,
our director, of course, used to feather through. Hey, not a problem. Just thought I'd pop in and double
yeah,
check. How you been?
yeah, yeah. Good, thank you. Good, good.
I'm
Just
glad to
waiting
hear it.
for other people to join before we start the training. You're welcome to stay if you want.
That's okay. I will duck away. No,
Yeah.
if you see the whiteboard behind me, there's a mountain of work to get done. Lovely seeing you again, though.
Okay. Cheers. Thanks.
Bye, guys.
Bye. Okay, we'll start in a minute or two. So welcome, Shannon. Welcome, Anil and Chris. Hi. So we'll get started in a couple of minutes. Just while we're waiting, so this lecture we're gonna talk about is on measuring and testing changes. Um, so I just wanted to get a rough idea from you guys, how much you know about this area. So on a scale of 1 to 5, where 1 is you don't even know what testing and measuring changes is, and 5 is that it's something that you've done a couple of times, at least in your role, in terms of collecting data to see if an improvement is happening in your area. So 1 to 5, just put that in the chat if you want. Couple more people joining. It's great. We'll get started in a second. Just for those who've joined, you put in a chat scale of 1 to 5 how comfortable you are with testing and measuring change. 1 is you don't even know what it is. 5 is that you've done it a couple of times already in your practice, you know, collecting data and then analyzing it and see whether there's been an improvement. So I know Chris can hear me. I just want to check with the others. They can hear me too. Just either put something in the chat or send a little thumbs up or put your hand up or something. That's great. Thanks, Anil. Okay. Great. I'm going to share my screen. Go. Okay, so testing and measuring changes. So we're going to find out about measures, how we plan them in our plan phase of the PDSA, and then what do we do in the do phase of the PDSA. We found out about PDSA on the last lecture, so if you don't know what PDSA is, you might need to go back to QI 102 and look all that up. But basically, it's the model which we use for improvement, and explain how to increase the size and the scope of subsequent cycles in the PDSA so that you're getting bigger and bigger changes. Using data for improvement is different to using data for research. Quite a few people are quite comfortable with collecting data for research. And usually in research, you're trying to gather enough data to actually prove or disprove your theory. So the amount of data you usually need to collect in research is a lot greater. It needs to be high quality. And there needs to be a lot of mechanisms in your data collection and usually in research to control for bias, which is the main thing which will mean that your results in research are not actually real. So research is all about trying to control the bias. In quality improvement, we're not holding ourselves to such a high standard. What we are trying to do is just gather enough data so we can see if things are going in the right direction. It might not necessarily prove that what we are doing is making that change, but we're not trying to achieve proof. What we're trying to achieve is improvement. So if something is getting better, then we've achieved what we want to achieve, even if there isn't a direct causal relationship. There may be an indirect causal relationship instead, for example. And what gives you more authority in a quality improvement study is change upon change. So you keep going in the same direction, you keep improving with subsequent changes that you do. That gives you more confidence that what you're doing is the right thing. So that's the difference between the two. And it's really important to know that difference, because whenever you're talking about data with other people who are not on your project, most people are using a research paradigm when they're interpreting your data. In other words, they're going to hold you to a higher standard than you're holding yourself. They might say, well, that doesn't prove anything. And you have to try and explain to them that you're not achieving a research level of proof. You're only trying to achieve enough information to keep us going in the right direction. So there are 3 types of measures. There is an outcome measure, which is the thing that we want to achieve, you know, where we are going. And it's usually a patient-focused outcome measure. So if you put yourself in the patient's shoes, you say, well, what is important to them? A process measure is things along the way to get us to that outcome. So it's what we are doing. You know, are we doing enough of this test? Are we doing it in the right amount of time? Are we meeting those targets? And this, we suppose that if we do all those processes correctly, then we're going to get the best outcome. A balancing measure is what people often don't really think about, but it's very good to measure, and that is unintended consequences. So what else is happening? What could happen as a result of your changes that you might not want to happen? Like, are you going to get more complaints? Well, if that's a worry, then you should measure how many complaints you're getting and see if they go up, for example. And when we're creating our measures, we want to use operational definitions, which is really precise way of defining what they are, how they are measured, which will mean that you can have consistent measures. So there are two levels of defining measures. There's one at the project level, which kind of looks over the whole lifespan of a project, which is typically spanning over years. And then there's level 2, which is PDSA level, which is your individual tests of change. So if you're going to test a specific innovation, then you might have some measures just to measure that particular thing for that time that you're implementing it, but you're not going to keep measuring that throughout the whole project. And the reason why you want to do that is because there is usually a proliferation of measures in any project where we end up at the end of a project measuring 30, 40 data points, which is really quite unmanageable. And so you want to really know what are the key things you need to know throughout the whole project, and what are the things you only need to know at stages along the way. So here's a little exercise. Identify the type and level of each measure in this QI project. So the first project is a rate of occurrence of MRSA per 1,000 patient days. The second one is % of patient encounters in compliance with hand hygiene procedure. The next one is number of hand sanitizer stations available. So I'll just give you a minute to think of those three, the answers to these three, and then I'll show you the answers. So for each one, which one is what type and what level each measure is. Okay, so here are the answers. So for the MRSA one, that's your overall goal. And if you've achieved it, then your project ends. So it's a project level outcome measure. The second one, to improve hand hygiene, is a project level, but it's a process measure. And there's also a PDSA outcome measure. So if we go back, we'll % of patient encounters in compliance with hand hygiene procedure. So at the project level, we want that to happen, but that's not the overall goal. The overall goal at the project level would be reduction of infections, for example. That is our outcome. This is a process to get you to that outcome. But at the PDSA level, say one measure is you put more sanitizer stations available in the working area, then at that level of testing, you would want that as your outcome. You know, if you've improved things, if you've improved the amount of times people use it, then for that particular test, you've achieved your outcome. So slightly complicated there. And then the third one, the first test is to try and improve hand hygiene by increasing the availability of hand sanitizers. That's a PDSA process measure. Okay, so how would you measure this outcome? Access to healthcare. So that's quite a vague, broad thing. You know, access. What do we mean exactly by access? What exactly is healthcare? You know, there's all different forms of healthcare that we have. Some of it you might not even call healthcare. Some of you might call wellness. I don't know, but that's quite broad. But it is typically broad, so you can apply it to your area. So my area, for example, would be colon cancer care. In your areas, it might be you know, breast screening or something like that. How would you measure the outcome in your area. So just give you a minute to think about that. And if you want to actually contribute, you can put some of your answers in chat. I'll give you a couple of minutes to do that. Okay, so there are many ways to measure access, of course. For example, it could be the number of days to the third available appointment. So if you're looking at a bookings sheet, it kind of gives you a rough sort of span as to how much availability there is there. Number of minutes from time of appointment to time to see clinician. So that would be in a clinic setting, you're supposed to be there at 1:30 and the time you actually see them is 2:30. That would be an hour or 60 minutes. Percent of good or very good answers on relevant patient satisfaction survey questions. So that's you asking patients, how do you think your access to our services? How easy was it to access on a Likert scale? Then you would get survey answers back like that with all the inherent biases that surveys have in them. Average daily clinician hours available for appointments. So you could see that 1 week we have good availability, you know, we've got 4 hours of availability, and then the next week we might have 0 hours or even -1 hours if somebody's working overtime just to catch up, for example. So which of these is a complete operational definition? We've got rate of occurrence of MRSA per 1,000 patient days. We've got percentage of patient encounters in compliance with hand hygiene procedure, or number of hand sanitizer stations available. Which is the most complete? Well, probably the first one, but there's still some other things you've got to think about. For example, how do you define occurrence of MRSA? Is it MRSA in a wound swab, or is it MRSA on inpatient screening, or is it only on those patients who come into the hospital and get screened? You know, exactly who are you talking about? For the next one, how do you define a patient encounter? So we typically have the 5 moments of hand hygiene, so that's probably the definition that most people would use. And how do you calculate the percentage? So if that's your denominator, sorry, if that's your numerator, then your denominator might be the total number of patient encounters in a whole ward. That would be very difficult to calculate. So that would be quite a difficult measure to actually achieve. And then the last one, number of hand sanitizer stations available. So that's a pretty objective thing. You can go around a ward and count them. But would you include ones that are empty, for example? Or would you only count ones that are full? And what would be a sanitizer station? Would it be just a bottle that's free sitting on the table over there? Or is it ones that are glued, stuck to the wall? So these are all sort of things you've got to think about and pin down. So we're always measuring the same thing. So key questions when you're measuring is what is all the data you need to collect? You know, both numerator and denominator. Who is responsible for collecting the data? How often will the data be collected, and how will the data be collected? And there's a couple of other things that I really always tend to think about is like, do we really need to collect this data? And there is one sort of golden rule is that the more you collect, the worse the data is, because data collection is an onerous task. And unless somebody is actually dedicated to doing the data collection, which is pretty uncommon in the hospital, then it's always going to be second fiddle to whatever other tasks they're supposed to be doing, clinical or non-clinical. And so it's a task to get out the way. And if you're faced with a form and it's got 20 different questions on it, it's pretty daunting compared to a form that's only got 3 questions on it, for example. You just need enough data to know if you're doing okay. So it is often a big mistake. It's often the mistake that the wish list of data is much longer than is feasible. So that's usually the first thing you need to do, is cut out a lot of stuff. A lot of data that goes in, data collection that goes in, is data to try and stratify your analysis. So for example, gender, age, these are all not outcome measures, but they help you slice and dice the data to ask specific questions. And people just can chuck those things in because they're standard demographic data. But you could ask yourself, is it really interesting to know the difference between old people and young people for this particular outcome? Is it really interesting, or do we already know the answer and we're just proving what we already know by collecting this again? And often the answer to that is yes, it's actually not that necessary to collect the data. So yeah, really make it as simple as possible. Another thing is that people like to collect free text data fields, and they are almost usually, unanalyzable. Even with the best intentions, say, I'll go and read all these comments, and people don't. So if you got a whole load of sort of categorical data and numerical data in your form, just almost don't put in any free text, because it's not worth it. The only time that I use free text is actually when I'm doing a qualitative analysis on something. So I'm asking people's opinion. And then I might actually only ask 3 questions, something like, out of 10, how do you rate it? And then the next question would be, okay, so you gave us a 7, what would make it an 8? And that would be a free text thing. And that would give you, as a manager, really good information on how to improve. And then the last question would be, have you got any suggestions for improvement? Again, giving you insight through somebody else's eyes. And that you're probably going to read all those free text, or most of those free text answers, because you're just looking for specific examples that you can adopt into your service. This is another thing that people don't think about, but it's really, really important. And that is, the default usually is, okay, we're just going to collect data on everybody. We're just going to start collecting data, and we're going to do it on everybody going forwards. And that is a very big task, and it's often not necessary. But it's just born out of a research paradigm where people want to know the ultimate truth. But you don't need to know the ultimate truth. You just need to know enough. And usually sampling is your answer to that. You can, for example, measure every 10th person that comes through, or you can just get a list and randomize it, and then take the top 30 and look at those notes. Or you can do a snapshot. So you can say, we're going to do it for this week, and then we're going to stop, and then we'll do it in a month's time for another week. Those make your data, those improve the quality of the data, because it means that people don't see this as just something, an ongoing pain that they need to avoid, but they see the light at the end of the tunnel. They say, okay, it's only going to last for a week, then I can get back to my normal stuff. So sampling is a really good technique. And then when you're planning for data collection, you need to establish what you want to learn about it. So that's what I've been going on about. And determine what measures are most helpful, i.e., cut out the stuff that's not that useful. Work to definitions, and those who are collecting the data need to know the definitions or have them written right next to the data collection tool so that you apply the right definitions. And then, of course, designate who, what, where, and how, etc. So when we're analyzing data, this is another big difference with research. You tend to collect all the data and not analyze, so you don't want to bias your results. Whereas with quality improvement, you measure and you analyze as you go along so that you have constant feedback, because it's that feedback that helps you improve. So when it comes to analyzing the data, you can just put it in a table like this, but you can't really see what's going on without taking a long look at the data. So in quality improvement, the best visual tool is a run chart. And so we look at this run chart here. In run charts, you always have time along the bottom axis. So it could be either consecutive patients, or it could be consecutive weeks or months, but there's always time along the bottom axis. And then along the y-axis, there is what you're interested in measuring. So in this one, it's the number of central line associated bloodstream infections per catheter days. And as you can see on this chart, it goes up and down quite a bit, and that's what we call normal variation, because our system has got a lot of variations, including the patients that come in. So naturally, things go up and down quite a bit. The orange line is the median. And then if you look towards the right of the chart, you can see that visually, there seems to be some sort of trend, a downward trend, where you get a lot less points above the median. You get a consecutive run that's below the median. And in the next thing, we're going to talk a lot more about how to analyze these and actually say whether if that is a trend that is caused by something that you've done versus something that's just random variation. So, but you can just glance at a run chart like this and probably say, yeah, we probably made an improvement around about December last year. So when we're trying to improve with research, like a randomized controlled trial, we will design the intervention so carefully over about 5, 10, 15 years, and then deliver that intervention to a large population, measure it all, finish that, and then analyze. And that takes a long time, but it gets you to an answer that you can possibly spread across a lot of places, different countries, different hospitals, etc. So it's applicable to more than just the people that you tested. But in quality improvement, what we want to do is we just want to make things better for the people we have in front of us. We're not so concerned about taking what we've known and then moving it to somewhere else. So we just need to know if this population is getting better or not. And so we do that with rapid sequential tests. And that's what the PDSA cycle is about. It's about starting off small so that you can do something quickly and gain momentum and also gain confidence in what you're doing, so that you do something small and then the next time you do it a bit bigger and a bit bigger. So it's an iterative process. And each time you get bigger is about 5 times rule. So for example, you might be having a new admissions process on a ward, and your goal is to is patient satisfaction. So the first time you might do 1 patient. That would be your first PDSA cycle. You do 1 patient, and then afterwards you just talk to them and find out about them, find out how they found the process. So you wouldn't maybe even have any measures apart from just interviewing the patient afterwards. That would give you information to go on to your next PDSA cycle to improve the aspects you found out. You would do that, maybe measure a few things, and you probably do it in 5 patients, maybe a day's worth of patients or an afternoon. You then analyze your data from that, and then you would be honing down on a couple of really key places where you need to improve. You would do that again in a whole week, for example, which would be about 5 times what you did before. And in that way, you're constantly improving key aspects of your admissions process until you're at the point where you're doing it for a month. And then you're almost at the point to implement, and it feels just like what you've done before. So the effort it takes to then just do that continuously is not much more than your previous test that you did. So that's how you gain confidence. You gain experience. So this is a bit of a busy slide, and I'm not going to read through it all, but it basically tells you what to do if you act once you get your results through. So sometimes you got to say, do I believe these results? Have I got enough data? Can I rely on this data? Do I believe it? And if the answer is no to any of that, then you're going to have to go back and repeat it, but change your data collection process. But if it is data that you can rely on, then you go on to analyze it, and then you decide what to change based on what your analysis tells you. So I'm now going to try and play this video for you. I'm just going to see if it will work. Just a moment. Let me need to share the audio settings. Go. Just gotta try and share the video. Can you give me a thumbs up if you can hear the audio? I'm just going to play it. Yep, great.
When I first learned the frameworks for improvement and how you do it, we talked about really understanding the current system, flow charting processes, doing cause and effect, doing lots of surveys, getting all the information, getting ready. And so I, as I advised people that way and saw what happened, I saw a lot of activity but no improvement. So everybody was doing flow charts, looking at their system, collecting baseline data, and we realized in that talking to some people, if we worked with some professionals, we said they got antsy with that. What is all this quality improvement thing? Why can't we make something happen? And so we went back and re-looked and rethought Deming's PDSA framework. And he said, why don't we just start running PDSA right at the beginning? We could do it in parallel if we need to do all these things. And so as we developed the model for improvement, we made that sort of a framework of don't necessarily need all the answers before you get started, and people. And so the whole idea of what cycle can we run by next Tuesday became sort of a mantra as a provocation for people to think differently about the system. It doesn't mean those other background things are important, but it means that we can actually get along, begin to learn something right away by starting a PDSA. And for a while that was in IHI's collaboration stuff, that was sort of a little mantra for us to get people. It's just a provocation, got people to think very differently about improvement, that we actually could do some improvement next week, even though we don't know that much about the system we're trying to improve. So I think that sort of changed the framework and made the model for improvement different than a lot of other frameworks that were available at the time.
Okay. Watching this video always cracks me up because Lloyd Provost, he's a nice guy. He's probably quite naive, and maybe actually someone didn't say to him, what can you do by next Tuesday? Maybe they said to him, see you next Tuesday, and he didn't know what that meant at the time, probably. But anyway, so what in your work area can you do by next Tuesday? So I want you to think a little bit about in your area, there's probably lots of things that you could make better. And a lot of those things are probably, things that would take 1 or 2 years to implement. So think of that grand aspiration, but then think, okay, if I was going to work towards that, what could I do by next Tuesday to at least get us one step closer to that improved goal? So try and think about that in your own work area. And if you got an idea, I'd love to hear it from you. If you unmute yourself and let me know. So has anybody got any ideas, or even just maybe you don't even have an idea of what you can do, but you know you got an idea of a problem in your area, and then we might be able to brainstorm it. Has anybody got anything to share?
I've got a simple one.
Thanks,
in
Rebecca.
regards- Hi, Kira. I work in IV, and one thing that we have is that we've got the alcohol wipes, which when you're in clinical practice, we've got the small ones and the big ones for CVADs. But those small ones are near useless with most of the things that we do. So having a lot of our practice just moving to the larger chlorhexidine alcohol pads.
Right.
Yeah.
Okay, so so you work in infectious diseases, is that what you said?
Now I'm an IV. I'm doing
IV.
both.
IV.
Yeah.
So you're
Yeah.
part of the intravenous access
Team, yeah.
team, yeah. And so when you're putting in a cannula, that's what you're talking about. When you're putting in an IV cannula or a PICC line or something, you want to disinfect the area with a swab. And the standard ones are tiny squares that are just not going to do the job, and so you're trying to move over to the larger, wipes.
Yeah, the larger wipes for more like your also just accessing your IV line. So at the moment we've got the small ones, but they don't really. It's very easy to contaminate the hub.
Yeah.
With the small ones even. So introducing them into most of our practice instead of having them as the only for accessing CVAD lines and also putting your cannulas in instead of having those small ones, which don't really decontaminate the area much. Having the bigger one, which would do a better job. So just
Okay, great. So
kind of making do with just
That's a good example. That's a really good example. So, I mean, I could think of lots of things that could, over time, make it 100% successful that you're using the larger wipes. And probably your outcome measure in that project would actually be infections, and your process measure would be the larger wipes use. And then what could you do by next Tuesday? Well, you could the place where you go to get these wipes, you could put a great big sign and make sure that they're obvious and they're easy to find, and you could make the little ones tuck them away somewhere where it's more difficult to get to, so then people are just naturally going to grab the bigger ones. That's something you might be able to do pretty quickly.
I do have to consider procurement, which also is but yes, making it more easy for people to access. That's a good idea.
Yeah, exactly. So I mean, you could do that, and then see if that improves things, and then you're left with a procurement problem then. And so although the procurement problem might be a problem eventually because you run out of these things, you could at least show that you could use those larger wipes a lot more often. Other things that you can do by next Tuesday are easy things like some sort of notice or email or teaching or education session that really hits through. Because, I mean, obviously you could send a quick email to everybody and most people would maybe read it and then forget about it. But if you could put up a poster or something like that, then that might be a little bit more effective, and a very simple thing to do by next Tuesday. So by doing that, you gain yourself a momentum, and you gain some encouragement that yes, we can actually make a difference, and we can actually do things pretty quickly without having to plan absolutely everything to the nth degree. So anyway, thanks very much for sharing. Shannon, you've got your hand up.
Yeah, can you hear me okay, James?
Yes, can.
Yeah.
Thank you.
Okay, I've been having problems with Teams. Yeah, I really liked that idea of not having to overthink it too much. I think sometimes I've come in with a bit of a research mind and feeling like the data has to be absolutely thorough
Rock
and
solid, yeah.
detailed. And I think probably just an example that could apply that what we could do next week would be there's an issue in our service just about how much time we spend in paperwork and that initial assessment process in one of our community teams down at the hospital, and people are open to it, but it's a big change of practice, and we seem to be going around the houses a little bit. But I wonder if next week we could just actually start by a quick survey, 3 questions. How much time do you spend on the initial assessment? How much time do you spend delegating? And do you think there is any opportunity for efficiency? And that might just get the wider conversation and everyone on board. So I thought that was really nice. Thank you.
Yeah, that's a really good idea. And then feeding back the results of that polls to everybody who's would spark up a great discussion about what we could do to yeah, brilliant. I like that. Thank you. Anybody else want to share? Okay, no worries. Well, I've got one thing to share with you here. So I don't know if you've heard about something called the Net Promoter Score. It's a bit blurry, I think, isn't it? But anyway, the Net Promoter Score is probably, if you were to ask one question to your consumers or clients or patients about how you were doing, then this is probably the single question which has a little bit of sort of science behind it. And it's like, how likely are you to recommend us to a friend? You know, so you see this quite often in commercial areas, but more and more so in healthcare areas as well. And the good thing about it is that it's quite sensitive to change. So if you put something in that gives your users, your service users, a better experience, you will shift the needle. It's calculated by asking them that question on a scale of 0 to 10. And then people who give you a score of 9 or 10, they're called promoters. They're people who are going to rave about you. They're actually going to go out of their way and maybe tell their friends and family how much of a good time that they had. You know, think of I don't know, if you went to a spa, for example, and you came back and you felt great, you would probably just spontaneously tell your partner or your friends, "Oh, I went to the spa and it was really good." So those are your promoters. And then on the other end of the scale, from 0 to 6 is your detractors. And a 6 sounds like quite a high score for somebody who's a detractor, but actually, yeah, this is the way it's made. So a detractor is somebody who would probably actually offer negative views spontaneously to people. So if they came away from your service with a score of 6 or below, they might actually go home and say, oh, I had such a long wait in clinic today. It was not so good, to be honest. You know, they've got something just get off their chest, and it might be just a throwaway comment like that. Or if they're down at the 0 end, then they might actually go to Google and start posting nasty stuff about you. But these are all the detractors. And then in the middle are the passives. They're the people who are going to say, yeah, it was fine. You know, they're not going to say great things, but they're also not going to say bad things either. So you take the promoters. So you take the number of detractors off the promoters, and you get a score between -100 and +100. And the absolute number, you can compare it with other organizations in the same sector. So if you knew what the Net Promoter Score for your clinic was, and you knew what it was for a similar type of clinic in another hospital, you could directly compare them. But what's also very useful is comparing it over times to see what your individual score does as you measure it over and over again, and you do things to improve the experience in that area. So the reason why I'm explaining this is because this is now a very simple measure that you can quite easily implement quite quickly in any area, either by pieces of paper with the old school analog way. Some people, for example, get some voting boxes and the receptionist gives them a token, and then on the way out, they just put the token in the box which they want to put. It probably wouldn't be 10 boxes, maybe 3 boxes, for example. Or you can send out a little email with just this one thing on it. So you could do that in your area, and then you could start thinking about some zero-cost ways to improve experience, patient experience, like I don't know, just telling the staff, okay, this week we are going to concentrate on giving everybody a smile when they come up to the desk. And that sounds like common sense, but human beings need feedback. So if you do that, and then you show those people on the desk that their smiles caused our Net Promoter Score to go up by 10 points in the last week, that's going to reinforce them to keep smiling more at the next people that come along. So that's one way that you could quickly change things. And it's about the feedback that really keeps those behaviors going. So that's just an example of what you could do next week to make a difference. And I really like the examples that were shared. That's really great. Are there any questions from anybody about testing and measuring change? None? Great, awesome. Well, I hope you have a great afternoon. Good lunch if you haven't had it already, and I'll see you next month. Thanks very much.